So let's move on now to our next panel session. And I reflect that 40 years ago, in my very first job, I worked for the Royal College of Obstetricians and Gynaecologists, and the very same problems that we're now going to talk about filled my day back then. Suboptimal monitoring and response to fetal heart rate changes have been repeatedly identified for a very long time as one of the most common contributors to preventable harm. And when there are concerns about a baby's well-being during labour, maternity staff need the right tools and support to be able to provide the highest quality of care. But just as important is communicating effectively with women and their birth partners and making sure that their concerns are listened to and that they're involved in decisions about their care. The Avoiding Brain Injury in Childbirth, and it's called by the acronym ABC, the ABC programme is a unique collaboration between this institute, the Royal College of Midwives, and the Royal College of Obstetricians and Gynaecologists, and it aims to provide support for maternity services to improve clinical practice. In this session, we're going to hear about how the programme applied the principles of co-design to develop a nationally standardised approach for the detection and response to fetal labour. And we're going to hear from two speakers, first of all, and then we're going to have our panel session. So let me introduce our speakers to you. Jan van der Scheer, Senior Research Associate at this institute, who's working on research programmes to develop participatory and consensus building methods that can be used time and time again for healthcare improvement projects. And very well known to you all, I suspect, Lisa Hinton, Senior Research Associate at this institute, who leads applied research programs with a focus on maternity safety. So let's hear first of all from Jan van der Scheer.
Thank you very much, Vivian. Absolute pleasure to be here today. I'll be discussing together with Lisa a few elements of the ABC program, the Avoiding Brain Injury in Childbirth program, a collaboration between two Royal Colleges and this institute, a program that has been commissioned by the Department of Health and Social Care. And what Lisa and I will be focusing on are these really important co-design elements that form part of the ABC program in its development. Before we go into that, a little bit more on co-design. When we read on the literature and some of the definitions of co-design, we read words such as human-centered, creative, iterative approach to, for example, service innovation. We also read about users becoming part of a design team as experts of their experience. We can read about using the collective creativity of a team with members from different backgrounds and different interests, all coming together with these different disciplines in mind to share their knowledge about the design process and the design content. So probably much more eloquently than what I was trying to do just now, Robert et al. Have described in the Element series, which you can find on the This Institute website, how co-design is about an intentionally applied process, not just something that happens as a coincidence, and then thinking about improving services through understanding experiences and using those. And this is also very much about adopting methods that we can refer to as human-centered, and with human-centered principles enacted through things like dialogue, empathy, creativity, self-efficacy, underpinning these co-design efforts. And what we know is that it has huge potential to help improve healthcare experiences, to potentially improve the effectivity and the safety of services. We definitely also know that there can be a really strong case made for a democratic rationale for this, so about enabling inclusivity and equity. And we can also see emerging evidence that co-design is indeed leading to healthcare improvement, for example, through enhanced learning at service ecosystem level. Definitely lots of room for strengthening the evidence base. And one area that is also really, really important to keep thinking about is what is the infrastructure that we have to use co-design as part of healthcare improvement efforts, such that these infrastructures can be built and used in a way to make healthcare improvement, both it's the doing of it in a systematic, evidence-based manner, as well as the evaluation of it, so that we can also keep generating evidence, that we also apply that thinking when it comes to the use of co-design. This is now where some of the work that we've been doing around the ABC program can be of help to try and understand what can be done, as well as to help generate and think about the infrastructures that are required. And the Avoiding Brain Injury in Childbirth program has as underpinning something that is, of course, immeasurable in its emotional cost: avoidable brain injury during childbirth. Beyond these immeasurable emotional cost, it is also an enormous financial burden to the NHS when we think about the litigation claims that are related to avoidable brain injury. What we have also learned, sadly, through, for example, the Ockham reports that you may have heard about and maybe even have read something of, is the essential learning to take on board to improve the listening to women and families when it comes to maternity services. And from here, two national priorities can be identified. One is about intrapartum fetal monitoring. It's a bit of a technical term, and I'll come back to that later on during this presentation. And also another type of risk for brain injury, and that's related to the obstetric emergency of impacted fetal head at cesarean births. So today what we'll go into, first myself, when thinking about the work with maternity staff members and co-design, and later on when Lisa is also speaking further, is that the approaches that underpin the ABC program, that are developed through the ABC program, they combine evidence and extensive user testing. Obviously, this is where the co-design elements become really, really important, as well as all the guiding by learning from women and birth partners and working together with them. So I'll start here with a few examples of detection and response to suspected fetal deterioration during labor. Another mouthful, but I hope by discussing some of the background of this a bit more that we can start to unpack what this technical term means. So the problem that we are trying to solve, I already referred to these litigation cases, and a lot of these litigation cases are related to detecting and responding to possible fetal deterioration. That means that a baby during labor, we can start to see signals of how that baby is coping with that labor. For example, if there's a risk of maybe oxygen deficit. And these different signals can be interpreted. And if we see that there's maybe, or at least in this case, the maternity service staff who are working with the woman in labor and their birth partner, if they start to see there is something maybe not as going as well as we would like to, they can respond to that, for example, to call in a senior staff member or an obstetrician to be able to further review if further action is needed. And this is where, with that risk recognition, when it relates to something that is referred to as fetal monitoring, is not going as well in all units as it should do. So, and one of the issues here is that there is a lot of focus on something that is, for example, called cardiotocography or electronic fetal monitoring. So that's a focus and a way of looking at what's happening to the heart rate of the baby during labor. And that's really important, but sometimes it's getting a bit lost. And the same with a different way of monitoring the heart rate called intermittent auscultation, is that we need to just look beyond just that fetal heart rate and look at other signals that might be relevant. For example, what's happening with the maternal temperature, what's happening with the number of contractions that a woman in labor is experiencing. And these signals together, they are really important to think about an effective system for detecting and responding to suspected fetal deterioration. So we need to think about something that is systematic, but also personalized. We need to make sure this is standardized so that we don't have this variation that we are currently seeing across a lot of different units. We need to make sure it's really easy to use and optimize for clinical use so that it doesn't interfere, of course, with the care and is actually strengthening the care that is being provided. And this is also where we'll dig into both myself in the next few minutes and Elisa later on, the really important combination of clinical expertise, lived experiences, and scientific evidence to bring those together to build this kind of effective system and the co-design with maternity professionals and maternity service users. So here are a few examples. So the first step as part of the ABC program was to bring together and invite maternity staff as well as maternity service users to come on board and join in a network with to take part in various activities to start thinking and working around this topic. And one of the things, so this is just one example of that, were interviews with midwives and obstetricians on the kinds of tools that are required to facilitate better detection and response of fetal deterioration. So what was, for example, done as part of the ABC program is a form of usability testing that is derived from human factors engineering methods, where two contrasting, in this case, tools, so these tools are prototype tools that could be used during the care for a woman in labor and the baby, to track at each moment what is happening and to be able to respond to that accordingly if there is, for example, an accumulation of risk factors. And these are two deliberately contrasting tools that, by a method of, you could say, think aloud, can really help to service some of the things that are working well with one design as well as with the other. So through that, we, for example, were able to understand better about the kinds of details that worked well with one of the designs, as well as the ease of completion and the layout of the other one, as well as underpinning, you could say, usability principles around minimizing duplication of effort, making sure that the escalation pathway, so who is called next, is included, and that we think more carefully or think further, I have to say, about the training. So through that, the multidisciplinary team, developed the next iteration, taking all that learning on board from the initial usability testing, and move forward with something that we refer to as shadow testing, simulations, taking part in different types of maternity units across England, comparing usual care to care provided with the prototype tools in different kinds of scenarios. So here we worked with cameras, with ethnography, but also with the feedback from the participants afterwards, after they finished the simulations. And by having this team on board, we're able to generate a lot of knowledge and ideas about things that are required to be further improved and that can inform future iterations. We did find there was a lot of enthusiasm for this kind of new personalized holistic approach. And it's perhaps not surprising, but still really important to note the number of concerns that were expressed by maternity staff about their current tools, and the current tools are the ones that we're using as part of their usual care simulation. And to finish this here, and before moving to Lisa's presentation, I think we also took another lesson from this, and we were able to both through the feedback from the participants, through the ethnography, as well as through the camera work, to see that it was possible to communicate well among the team and with the women and birth partner. But there was a very clear tendency to perhaps get a bit preoccupied with this new paperwork, and you could say huddle in a corner of the room. There was awareness of this, but we definitely found and learned more lessons that we were able to use in subsequent iterations and further development of training programs, how ergonomics and training around this, about this really, really critical aspect are key. So from there, I'll hand over to Lisa, and thank you very much for now.
So thank you, Jan, for introducing co-design in the ABC programme. As Jan's already mentioned, the outstanding feature of the ABC programme is that it has been co-designed with maternity staff and with the people who use maternity services. Jan has just outlined how the ABC programme has used co-design to incorporate clinical expertise and scientific evidence. As the shadow testing revealed, communicating concerns and reaching a shared understanding with women and birth partners was an area that needed support. In this presentation, I'm going to describe how we develop principles for what good looks like for women in communicating around fetal surveillance, and how we incorporated maternity service user voices into the co-design. So fundamental to the ABC approach is that the person in labour and their birth partner must be included in all discussions and decisions, and that their voices are heard. Our deep listening to these voices has been underpinned by two overarching activities. First, our work with the core patient and public involvement group, and second, our listening to women and birth partners. The co-design with maternity service users was operationalised through our core group of patient and public involvement advisors, who worked closely with the ABC programme to provide input throughout, ensuring that listening and communicating with women and their birth partners was a golden thread that ran throughout the programme. This core group of advisors comes from diverse backgrounds. All work in advocating for safe and personal childbirth. Regular meetings held throughout the programme were online. Their input was sought on the full range of ABC programme activities and ensured diversity and inclusion. Their input helped refine communication principles and the training packages for the detection and response to suspected fetal deterioration and the obstetric emergency of impacted fetal head at caesarean section. And I will take each of these in turn. So the core principles underlining the ABC approach included co-design with maternity service users. Our regular meetings with the core PPI group supported this co-design, and I will come back to describe how their inputs impacted on the programme in a few minutes. But before that, a couple of slides on how we developed an understanding of what good communication looks like during fetal surveillance. Building on our expertise in engaging with women and birth partners on experiences of maternity care, we undertook a wide listening exercise with women and their birth partners. Emphasis on reaching diverse range of voices was key. We first used an animated vignette and invited responses on what good looks like in communication around fetal surveillance via a survey, interviews, and focus groups. We heard from over 200 women and birth partners from across the UK, including 42 interviews and 137 survey responses on what good looks like when communicating concerns about fetal well-being during labour. Women and their birth partners called for better information, clear communication, and involvement in decision-making, and we developed a set of 5 principles for good communication. We also conducted 3 focus group workshops with a total of 26 women, online and face-to-face. These focus groups were focused on capturing perspectives from underserved and under-researched populations. They were facilitated by the Motherhood Group and Birth Companions, both groups who are advocating in this space, and enabled us to sense-check the communication principles for cultural competency. The result of this deep listening was a set of 5 principles for good communication in relation to the detection and response to suspected fetal deterioration. Building on these principles, the ABC programme has enabled the design of practical, bespoke tools and communication resources, including actionable prompts for ensuring respectful and collaborative relationships with women and their birth partners. During our regular online meetings, our core PPI group helped us refine these principles further. One example is where their input also suggested the inclusion of a question on the ABC intrapartum tool that Jan introduced in the previous presentation. The question, "Is the woman concerned?" aims to enable and engage the person in labour and let them know that they are involved throughout the labour process. For managing the obstetric emergency impacted fetal head at caesarean section, a major focus has been on the experiences of women and birth partners in situations where there are deviations from what the birth that the woman had planned for. Communication with women and their birth partners is crucial in such obstetric emergencies. What you say and how you say it can have a lasting impact on individuals, and listening and showing empathy can help in these challenging situations. So we built on the communications principles that we developed for fetal deterioration already described, but recognizing that communication might be different in an emergency situation, we used bespoke patient and public involvement engagement with an additional 15 women who had experience of obstetric emergency, and also pilot tested the intervention and used these inputs to develop communication principles for the obstetric emergency impacted fetal head at caesarean section. These 3 principles, as opposed to the 5 for fetal surveillance, focus on the importance of communication, clear language, and including birth partners. And these principles informed the training materials and the algorithms that we have developed to support this training package. To illustrate how these are used in the training materials, I'm going to talk you through just one: communication. So the key messages to come out of this work is that it's really important during the obstetric emergency to allocate a specific team member to communicate with the woman and their birth partner, to be honest, and to explain early on the possibility of an impacted fetal head. During the emergency, it's important to clearly explain what's going on over time and check that the woman and her birth partner understand what's happening. And in preparation for caesarean birth, explain the need for possible vaginal manoeuvres. Communication also is nonverbal, and it was important that staff members realised that nonverbal communication can be just as important as what you say. Reassurance when communicating can help reduce anxiety. Being mindful that conversations in earshot of the woman and their birth partner can be distressing or anxiety-provoking. And in parallel, that silence may cause women and birth partners to think the worst. We developed these key messages, but also our work with the PPI group suggested that the training materials be supported by quotes and also some conversation starters, some suggestions for how staff might be wanting to introduce these ideas within the obstetric emergency itself. Safe delivery of an impacted fetal head requires effective team working, communication, and technical skills. Our engagement work with women about communication during an obstetric emergency also helped us co-design these algorithms, which include the core communication principles. And these are going to be part of the training package that will be rolled out as part of the ABC programme. One very clear example of the impact of the co-design that we've undertaken is the impact on this particular algorithm for abdominal cephalic disimpaction. Consultation with the PPI representatives attending our pilot testing helped design the inclusion of the need to explain the possibility of vaginal manoeuvres. So, developed through co-design with maternity care professionals, women and their birth partners, these algorithms will guide maternity staff in the management of this complex emergency using a structured and stepwise approach. Thank you very much for listening and looking forward to the conversation.
So 2 really clear presentations there from Lisa and from Jan. We're now going to bring in 2 further panelists. So I'm delighted to welcome Bothaina Attal, who's Research Associate at this institute, working in applied research, looking at women and birth partners engagement for improving mental health care and safety, and Matt Woodward. Matt is also Research Associate at this institute, who specialises in human factors, ergonomics and decision making. So hello to both of you, and let me start off with Bothaina, if I may, because we've been talking about involving mothers-to-be and their partners. And we know that one of the greatest issues at the moment is inequity in maternity outcomes, which has been highlighted in a mass of recent reports, like 5 times more. How do you make sure that in this kind of work that you bring in people who may be suspicious of authority and for whom very often English is not their primary language?
Well, thank you, Vivian. Well, this work is similar to the healthcare picture or landscape. It's a complex landscape. It's affected by all the social and structural constraints that impede the access of certain communities into the healthcare services. So I would say, from the experience on the ABC and from the lessons we learned, the first step will be really a consideration of the communities we need to include or to represent, although we will not be able to be realistic to include and represent every single person, of course, but this is a strive, an effort. So we start with the planning of the program to know who are really the people who we might call hard to reach, Black communities, ethnic minorities, as you mentioned, also women and those in labor whose English is not their first language. So we start with the planning, actually, from the start. We need actually also to put resources into recruitment of these communities, into the public patient and public involvement work in what we do, in the quality improvement. So second step, I would say, is actually effective PPI, public patient and public involvement, making resources available in terms of time to recruit these communities. We need budgets to reach out, network, represent these communities. We need also to have culturally competent researchers. These are researchers with knowledge and experience in culturally sensitive strategies and approaches, understanding the background of the people who we need to serve. We need really to tap on the resources and networks of the people we have invited into our patient and public involvement group. Examples from the ABC, like one of our contributors helped organize and facilitate one of the focus group workshops that Lisa mentioned. And I would say also people from ethnic minorities need also to hear back from our work. So also effective feedback back to the communities about the work and its impact on the health services.
Thank you. Lisa, how difficult is it making sure that you have a vocabulary, you had a brilliant vocabulary that you outlined in your presentation, that is also appropriate for a wide range of different ethnicities, and or people who are perhaps non-verbal. And the other bit of it is, how difficult is it to do co-design in maternity? Is it different to doing co-design, in other patient populations?
Yes, I think it is. I'm going to answer that question first, Vivian. I think one of the challenges around doing co-design and any work in maternity is just a consideration of what a vast and complex field it is. I mean, every child that's born in this country has got two parents who have experience of the maternity system. We all have or many of us have experience of the system. Some people have very simple, uncomplex journeys through the system, others less so. And of course, the system involves lots of different settings. You might have freestanding midwifery units, but also obstetric units. And the clinicians who are working in maternity are wide-ranging, from obstetricians to midwives, to maternity support workers, to anaesthetists. So doing co-design in such a complex system that impacts so profoundly on our society is challenging, to make sure that you've incorporated all of those views. And then, of course, making sure that we are doing work that speaks to the diversity of the populations that Bothaina has just been talking about is an additional challenge. So to pick up on your first question, how do we make sure that we're speaking a language and a lexicon that that as many people as possible can understand? It's a huge challenge. And one of the principles that we worked with in the ABC program is making sure that with MTPI, we had people who were advising us who were expert at reaching across different groups and making sure that the language that we were using was as accessible as possible to everybody. But language and translation services in the UK is a real challenge. And then, of course, we need to make consideration of those for whom reading is not easy, kind of broad range of learning abilities, etc. So it is a challenge, but I think recognizing the challenge and working as much as we can to overcome it and doing that work. I was really struck in the earlier presentation by Jane O'Hara's phrase around relational work being work. And I think, that the work that we do in co-design with maternity service users is also work and needs to be intentional and very proactive.
I'm going to come, thank you. I'm going to come to Matt now, because, all we've heard makes you think, oh my goodness me, the challenges for co-design in healthcare, but the challenges for co-design in maternity are probably overwhelming. How did you overcome these for ABC?
Good question. We made sure we had representation from lots of these different contexts, these different types of units. So when we went out and asked our clinicians to have a go at using our prototype tools, we made sure we were covering all of those different settings. I think another issue that we can often have is getting hold of clinicians' time. Their time is incredibly valuable. So we have to be flexible with our methods to make sure we can make it easy for them. So, for example, early on in our study, we ran these usability evaluations where the prototype tools were being tested out against scenarios. Now, typically, you might spend time doing that in person, but we adapted the method so that we could run it online. It made it easier for people to participate and easier for us to get views from all around the country, lots of different units and different types of setting.
It must have been, I was thinking about how difficult it must be during a full-on obstetric emergency to have a whole load of ethnographers in the room as well, and all those other people. And you have, and also the problem that you have of going back to women who've given birth and then asking them afterwards what they think, when the very last person they want to see when they've got a brand new baby is a person asking questions because they're so occupied. So how do you overcome just some of those really, really practical problems?
Well, I think a method that worked really well for us on this project was using simulations, because sometimes, as you say, having lots of researchers on the ground in the live context, it has many challenges around access and so forth. And also remember, we were conducting some of this study during the time of COVID, where we had to be very careful with risk management there. So being able to use simulation rooms in which we had participants from from mothers' groups. We were able to have clinicians, but in a kind of a safe space. It meant we could set up cameras and we could have group debriefs. I think all of that actually was a really effective way to see how these things worked in practice, but without having to step into the live world of actual PPH emergencies or births going on.
Jan, I wanted to ask you about how you reconcile different perspectives to reach a consensus, because you've got a lot of clinical staff and they may have very different views of what might work in a healthcare setting, which is different from service users or patients and carers. So there's a lot of different threads to bring together, aren't there?
Yeah, the complexity we've already discussed. Perhaps a few examples of how we've gone about with it in this maternity program, or a few other examples as well that are presented on the Distance 2 website. One is around consensus building techniques. Some of you may be aware with the Delphi techniques, where you can bring people together and share views, and through several rounds can reach a form of consensus. Another can be, and I think this is also something that I really felt and hear resonating in the first session of today at this space, this idea of bringing people together to hear each other's stories and views. This can be done, of course, through, for example, through focus groups or debriefs that Matt already mentioned, but also in other asynchronous ways. For example, by doing the work with patient and public involvement, synthesizing those views, then bringing those to a multidisciplinary, you could say, expert group that is trying to bring together these different threads of information that are also, for example, receiving inputs around the views of clinicians from the testing and from their views on, for example, the tools. And I think that's really important, because then you can start to work and think together around, hey, we have this shared goal, even though not each and every bit of what I would like to see coming back is going to be in there. But I'm being heard, I'm being listened to, and I can really understand why we are reaching this compromise. And perhaps the third and last one, at least for now, could be around doing iterations. So this is something that we definitely applied and took from, for example, human factors engineering. This idea of running through not just one or two, but we're talking about 5, 6, 7, 8 iterations, every time thinking carefully about new inputs, which can come from additional forms of usability testing, whether it's these interviews or think aloud interviews, formative design usability testing I spoke about in my presentation, or, for example, the simulations that Matt also mentioned. And there, again, we have opportunities to bring together these different voices. Also, if those voices are not immediately expressed in that particular, let's say, this really like intense feedback session. So there's a bit more space and time to work those in. And I think the example that Lisa gave in her presentation about how this additional bit in the tool is represented there is a really good example of that slightly perhaps slower, deliberate, but very systematic work of achieving that.
Thank you. I'm going to give Lisa the floor for our final question, and you've got about a minute to answer this, Lisa. So it's your top tips, really, is what's the learning for next time?
I think the learning is to be intentional, to understand that if you include voices in the process, they have the potential to add and improve the outcomes that you're working towards. Be transparent and to be democratic. I think those would be my top tips.
I hope you all wrote those down, because they were really top tips. But if you didn't, not to worry, because after this event is over, you will be able to look at this again many times if you wish, to get the full flavour of everything that's been said. So thank you to our speakers and to our panel. That was such a good session and such an important problem that we've been trying to crack for so many years. It's great to see this work.